Inclusion for All Action Hub, Wednesday, 6th of April, 2022. Zoom online. Chairperson, Jonathan Phillips. Attendance. Name, followed by job title and organisation. Tatum Yip, Community Project Worker, Healthwatch Leeds. Jonathan Phillips, Board Director, Healthwatch Leeds. Gemma O'Connell, Administrative Support Worker, Healthwatch Leeds. Rosie Horsman, Leeds Teaching Hospital, NHS Trust. Caroline McKay, Involvement and Communications Manager at Leeds Clinical Commissioning Group. Zaira Khanum, Physical and Sensory Impairment Development Worker, Forum Central. Michael Brady, Deputy Director at Patient Equalities at NHS England and National Advisor for LGBT Health. Sabrina Brown, Patient Equalities at NHS England. Lydia Robinson, Health Improvement Specialist, Personalised Care. Syed Ahmed, Head of Patient Experience, LYPFT. Helen Rowland, Quality Lead, Clinical Governors Team, Leeds Community Healthcare. Helen Butters, Communications, Insight and Involvement Team, Leeds CCG. Anne-Marie Barrell, Health Facilitation Team, Leeds and York Partnership. Catherine Carter, Project Worker, Change. Dominique Burley, Project Worker, Change. Stacey McCurley, NECS, North of England Commissioning Support Services. Jack Edmonds, NECS. Malcolm Pearce, Senior Manager, NECS. Dan Neville, NECS. Elaine Ray, Principal Performance and QA Officer, Leeds City Council. Nidesh Jandu, Association of Blind Asians. Victoria Tredenick, NHS, Leeds CCG. Maka Khan, Leeds Deaf Forum and Leeds Involving People. John Beale, Chair, Healthwatch Leeds. Melissa Barker-Simpson, BSL Interpreter. And Richard Jackson, BSL Interpreter. Apologies. Name, followed by job title and organisation. Audrey Okiafosu, CCG. Bushra Javed, Volunteer and Peer Advocacy Manager, Advanet. Caroline Bamford, Head of Diversity and Inclusion, LYPFT. Emma Wilson, NHS England and NHS Improvement. Hannah Davies, CEO, Healthwatch Leeds. John White, Lead Nurse for Patient Experience, LTHT. Julie Royal Evatt, Strategic Health Facilitator, LYPFT. Karen Shakespeare, Senior Project Manager, Leeds Care Record. Maksud Sheikh, Regional Campaigns Officer, Yorkshire and Humber, RNIB. Tashal Bhatia, Service Manager, Health for All. Abbreviation list. Accessible Information Standard, AIS. Healthwatch Leeds, HWL. Leeds Hearing and Sight Loss Service, BID. Leeds City Council, LCC. Leeds Community Health, LCH. Leeds Teaching Hospital Trust, LTHT. Leeds and York Partnership Foundation Trust, LYPFT. National Federation of the Blind, NFB, NHS Leeds Clinical Commissioning Group, Leeds CCG, Team of References, TORS, Leeds Care Record, LCR, Friends and Family Test, FFT, Leeds Society for Deaf and Blind People, LSDBP, Health Access for Refugees Programme, HARP, and Integrated Care System, ICS. BSL Rapid Review. Dr. Michael Brady. The following information is a transcript of a PowerPoint presentation titled Rapid Review of BSL Commissioning Arrangements, presented by Dr. Michael Brady, NHS, E/I. NECS, Partners in Improving Local Health. NHS, North of England, Commissioning Support Unit. Background and approach. Background. NECS were commissioned in November 2020 to undertake a rapid review of British Sign Language service provision across England, working with key national and charitable stakeholders and service users. The review's 3 stages consisted of the following. Number 1. Engagement of BSL stakeholders. Number 2. Options appraisal of where commissioning responsibility rests and how access to BSL interpretation might be provided. Number 3. Recommendations on the most appropriate and effective commissioning options that will improve access, patient experience, and provide value for money. The broader context of the review was to establish whether COVID-19 had exacerbated some of the pre-existing health and wider inequalities on deaf communities, and identify areas that may be addressed nationally and locally within systems, through commissioning or other considerations aligned to the emerging roles and responsibilities of integrated care systems. The review was able to establish that whilst acknowledging there being a number of areas where improvements to services are required, there are systems that have successfully engaged with their local population, developed a collaborative approach, and are delivering higher quality BSL services than elsewhere. Approach. The review was time limited to 8 weeks. Our approach comprised of 3 phases. First, engagement of relevant stakeholders to understand the challenges they face. Second, an options appraisal of where commissioning responsibility rests and how access to BSL interpretation can address health and inequalities. Finally, recommendations on the most appropriate and effective commissioning options that will improve access, reduce service variation, improve the patient experience, and deliver better health outcomes. A fundamental part of our review focused on stakeholder engagement, including deaf people, national charities, professional bodies, and NHS policy leads. A high-level desktop literature review of key relevant papers already in circulation and areas of best practice which assisted our thinking on the proposed future commissioning arrangements. What you told us. Stakeholder engagement. We engaged people with lived experience through interactive Zoom sessions supported by BSL interpreters. These include charities, BSL interpreters, service users, adult and children, National Union British Sign Language Interpreters, and Royal National Institute for Deaf People. We hosted over 25 interviews with policy leads, spanning primary care contractors, secondary care and mental health trusts, clinical commissioning groups, and integrated care systems. we hosted interviews with areas of best practice across the UK that were known to have good BSL experiences. Engagement focused on achieving a further understanding of challenges BSL users faced in accessing services prior and during to COVID-19, and how the pandemic was impacting on their current experiences, and capturing examples where service users had identified good patient experiences. How future services could be improved to meet patient expectations aligned to the strategic direction of NHSE/I, and the legal responsibility of commissioning organisations whilst identifying areas of good practice. What we heard. Some of the key issues we have consistently heard from the review work are problems in accessing BSL interpreter support, especially at short notice. Friends and family, including children, having to interpret in the absence of proper BSL support. A lack of consistent provision within a local system. Problems with handover arrangements between local services. Mixed quality of interpreting support when provided. Strong support for services provided locally involving the VCS. Much of the BSL support feeling distant and unaccountable locally. Long waits for interpreter support from national providers. Confusion and/or lack of awareness between the different BSL support services. Clinicians, managers, and administrators being unaware or unwilling to use BSL support. Lack of awareness of the legal duties linked to BSL support and the accessible information standards. Provision frequently likened to a postcode lottery in terms of access and quality. Duplication and confusion in who is providing the services. Priority areas. Stakeholders were asked to consider their perception of the most important areas of focus for the next 2 years for commissioners to take into consideration. The bullet points below highlight the areas that stakeholders viewed as a priority for BSL users. Choice of face-to-face and online BSL interpreter services. Improvements in quality of BSL interpreting services provision through commissioning standards. One point of access for online BSL interpreting provision. Local systems working together to commission face-to-face BSL interpreting services. Better engagement with service users to enhance commissioning standards and monitoring of services. Strengthening relationships between commissioners and national bodies, RNID, COD, etc. Empowering service users to become more familiar with using digital technology. Greater range of service user information in different forms of communication to improve choice. Self-serve access to an information service online advocacy role where service users can ask questions. Supported implementation and sharing of best practice on accessible information standard to minimise variation. Ensuring fair provider terms of engagement for BSL interpreters. Recommendations. BSL recommendations. A total of 17 recommendations were agreed with NHSE/I, which have been grouped under the following 3 broad headings. Number 1. Each ICS health system establishing consistent provision across primary and secondary care through a single BSL service to improve local services by bringing the existing multiple separate arrangements within a system together. Number 2. The strengthening of local provision is complemented by recommended enhancements to the existing national 111 BSL interpreter provision in emergency, urgent, and out-of-hours situations. Number 3. The final set of recommendations seek to address the variations in the quality of interpreter support, build awareness of the need for timely BSL services, whilst supporting clinicians, managers, and administrators how to access and effectively manage local BSL support provision. Developing a single ICS system-level BSL service. The specific recommendations to be badged as best practice are that R1. A best practice guide is produced by NHS England, setting out the issues faced by BSL users and recommending a coordinated ICS approach to providing face-to-face and video relay BSL provision based on clinical need. The coordinated service should provide a single point of access and accountability for service users, clinicians, and administrators, irrespective of which local NHS services they are accessing. R2. As part of the best practice guidance, each ICS is encouraged to establish a lived experience panel to support a review of existing BSL services, advocacy arrangements, and to undertake an initial Equality Impact Assessment, EIA, to consider the impact of COVID-19 on BSL users in their system. The lived experience panel should play a role in the ongoing review and monitoring of improved local BSL provision and undertake future EIA reviews. R3. Each ICS is encouraged to agree a system plan to commission coordinated BSL services for the populations in their ICS, based on agreed national minimum standards that enables work with local VCS providers. R4. Each ICS is encouraged to set out a plan, including provision within their service specifications, to promote and increase awareness across clinicians, managers, and administrators. R5. Each ICS is encouraged to establish a BSL advocacy support service to address operational and quality issues on behalf of BSL users. R6. A set of best practice case studies are developed to share alongside the ICS guidance to demonstrate the positive impact of bringing services together and of involving service users and the local workforce in the process. R7. The best practice should also encourage local work to understand the availability of BSL interpreters within each ICS. Each ICS is encouraged to develop an adequate market for suitably qualified and experienced interpreters, and/or to consider an employment model. This work should be based on an understanding of the potential to provide services within the local VCS, including consideration of the necessary payment levels to ensure access to high-quality interpreter support. Developing the National Urgent and Emergency 111 BSL Interpreter Support Service. R8. An enhanced national service is developed for urgent BSL support across England within NHS 111. This would include the BSL interpreter input to the Clinical Assessment Service and provide urgent and emergency BSL support. R9. A national group involving ICSs, national charities, 111 BSL leads, and BSL users review the existing 111 BSL support service and co-produced revised specification to meet the needs of BSL users. Declarations of interest will need to be recorded. R10. The potential volumes of additional activity are modelled by the 111 analytical team This work would identify the future demand on service provision, with additional levels of urgent support. R11. A review is undertaken by National 111 commissioning leads as to the best commercial, contractual, and procurement route to implement this service enhancement and how any recharge would work. R12. NHS England and Improvement and each ICS promotes the availability of the enhanced NHS 111 BSL service to healthcare professionals, managers, administrators, users, and relevant stakeholder groups alongside improved local system service provision. Improving quality and education linked to BSL support. R13. Minimum national standards are applied for the qualification and experience of interpreters across all ICSs and national services. R14. National work is undertaken with relevant charities to promote education for BSL users on how to make best use of empowering digital technology and support to successfully access health services, including promotional and tutorial videos on BSL. R15. The AIS is reviewed and updated to reflect the changes in the system provision, supported by a local implementation plan. R16. National work is undertaken with clinical professional bodies to promote awareness of the issues and solutions linked to BSL service use. R17. National work with the CQC is considered to increase their role in ensuring the needs of BSL service users are included within regulation. Progress against the recommendations. Developing an enhanced single National Urgent 111 BSL interpreter support service. We held a valuable workshop with national charities in September on how the NHS 111 service could be improved for BSL users. The workshop generated a lot of creative ideas, which are currently being considered and prioritised by NHS 111. We have worked with Sign Language Interactions Group to refresh a QR code that links directly to Sign Video's BSL support. We are taking steps to make the QR code available on the NHS 111 website. Further work with NHS 111 is planned to enhance the service for the deaf and hard of hearing community, including an NHS 111 BSL downstream pilot and NHS 111 online, taking steps towards BSL information videos. Improving quality and education linked to BSL support. We have held some helpful conversations with the Care Quality Commission on their approach to quality. NHS EI will now work with professional bodies to increase awareness. Next steps. Each ICS developing common BSL services for their populations. Complete the process to allow the Rapid Review Report and Best Practice Guide to be hosted on the NHS England website. Meet with ICS regional leads to introduce Best Practice Guide and request agreement to implement the content and assurance framework. Developing an enhanced single National Urgent 111 BSL interpreter support service. Promote BSL services that currently exist in NHS 111. Pilot a NHS 111 BSL downstream service. Take steps towards developing NHS 111 online BSL information videos. Improving quality and education linked to BSL support. Set out a plan to increase awareness across clinicians, managers, and administrators of BSL users' needs and legal entitlements, including medical professions and royal colleges. End of PowerPoint presentation slides. Reflections and questions. Quality, choice, and consistency are the most important aspects in all of this. Individuality also needs to be considered. Important to note that interpreters are needed in emergencies and they are rarely ever available, needed 24/7. Deaf community needs to stay involved in decisions and needs to be updated as these progress. Maka notes that they feel frustrated and things never seem to change. How do we support the deaf community's well-being is a question that arises. The video of the review summary needs to be made clearer to deaf people in terms of the recommendations and changes. Although it's in BSL, still not very accessible, since a lot of jargon was used, such as the term ICS commissioning. It will be useful to add subtitles and audio to meet different communications needs. Dr. Brady responded, "It's powerful to hear the local reflections, and they reinforced what they heard across the county. The video is currently aimed at professionals, but will work on the version for the public, which will be easier to understand and more accessible." AIS Review Update and Discussions. The following information is a transcript of a PowerPoint presentation titled 2022 National Review of Accessible Information Standard, presented by Malcolm Pierce. NECS, Partners in Improving Local Health. NHS, North of England, Commissioning Support Unit. What is the Accessible Information Standard? The Accessible Information Standard, AIS, published in 2016, applies to service providers across the NHS and publicly funded adult social care. Applicable organisations have a legal duty to take steps or make reasonable adjustments to follow this standard. The standard says that patients, service users, carers, and parents with a disability or sensory loss should be able to contact organisations and be contacted by organisations in accessible ways. Examples of this are communicating by email, text message, or text relay. Get information in a way that they can read and understand. Examples of this are Braille, Easy Read, and large print. Get communication support from a professional if they need it. An example of this includes the provision of a British Sign Language interpreter. Get communication support from health and social care staff if they need it. Examples of this would be if a person needed to lip read or use a hearing aid. Successful implementation will lead to improved outcomes and experiences, and the provision of safer and more personalised care and services to those individuals who come within the standard scope. Note: the Equality Act 2010, Section 212, states that substantial means more than minor or trivial. The Act is explicit in including the provision of information in an accessible format as a reasonable step to be taken. Scope of the review. NHS England and Improvement, NHSE/I, commissioned the 2022 National Review of the Accessible Information Standard, working with North of England Commissioning Support Unit. The review will build on the findings from the Healthwatch England Qualitative Review, Sign Health and Partners Survey, and the emerging SENSE review. The purpose of the AIS review is to undertake a detailed review of the AIS, working with a wide variety of stakeholders based on the existing scope and groupings including the findings made in the 2017 review. This review will also include an assessment on whether COVID-19 has had a material impact on providers meeting the existing standard. Provide a set of evidence-based, future-proofed recommendations for NHS E/I to consider. These would outline potential future considerations for AIS, including changes to the scope of the standard aligned to the Health and Social Care Act, NHS E/I planning and operational guidance, integrated care systems, and other national policies. Ensure the proposals and recommendations meet the legal responsibilities of NHS E/I. Increase the overall awareness of the AIS and review the legal responsibilities of organisations falling within the scope of the standard in meeting compliance. Improve outcomes for patients by ensuring that, where possible, communication preferences are met. Governance arrangements and approach. AIS governance model. Programme oversight and delivery is the NHS England and Improvement AIS Programme Board. They are responsible for the review of Accessible Information Standard and make recommendations on the change and implementation of the Accessible Information Standard. Underneath the Programme Board, there are the advisory and feedback groups, which consist of AIS Reference Group and AIS Coalition Groups. The AIS Coalition Groups have 4 thematic groups. They are Learning Disabilities Group, Sensory Loss Group, Mental Health Group, and Other Communication Impairment Group. Our approach. A fundamental part of our review is focused on stakeholder engagement, including charity organisations, representative service users, health and social care providers, Care Quality Commission, HOPE network. The review also focuses on engagement with and across the 4 AIS coalition groups: learning disability and autism, sensory loss, mental health, other communication and information needs. To date, over 64 workshops and interviews have been held with over 177 participants. Our findings from engaging with a cross-section of stakeholders have helped us to capture the findings and start to compile an evidence-based set of recommendations based on lived experience of the AIS and drawing in the findings' recent surveys. External AIS reviews: Sign Health Collaboration and Health Watch England. Sign Health Collaboration Review. Charity Coalition Review of the AIS, led by Sign Health. Implementation of the standard by providers was inconsistent and often poor. The Charity Coalition survey found that only 11% of patients covered by the AIS had equitable access to the NHS, and 81% of patients reported having an appointment where their communication needs were unmet. Professionals responding to the survey indicated that 31% of the providers they work for have implemented all 5 steps. Provision of information, including letters and leaflets in alternative formats, was rarely experienced by service users. 77% of people with information needs reported rarely or never receiving information in alternative formats. Access to primary care was highlighted as a particular challenge. 67% of deaf people reported that no accessible method of contacting their GP has been made available to them. Professionals are frequently not being offered training on AIS. The Charity Coalition survey, 37% of professionals reported that no training on the AIS had ever been provided. There was also low awareness by health and social care providers of the AIS itself, with 1 in 3 providers being unaware or unsure of the existence of the AIS. Complaints procedures were a particular area of challenge, with very few being reported as accessible. 41% of complaints procedures were reported as accessible by professionals, and 23% of patients reported experiencing an inaccessible complaints procedure. Healthwatch England Review. Healthwatch England undertook a thematic analysis of evidence from across local Healthwatch, feedback and research and engagement reports. Freedom of Information Access (FOI) requests were submitted to NHS trusts asking how well they had implemented the AIS. Key themes arising from the review include: the review found that people's communication and information needs were often overlooked when accessing services. For example, blind people being given forms to order a white cane, and appropriate support was not often in place to meet needs. Whilst there were examples of good practice, overall services were inconsistent in implementation. Individuals did not always receive support, even when their communication needs had been recorded. Of the providers who responded to the FOI request, only 35% claimed to fully meet the Accessible Information Standard. Recording and sharing of communication and information needs is inconsistently undertaken by providers. 24% of NHS services who responded to the FOI request said that they do not record people's communication needs on their patient file, or only do this some of the time. 57% of NHS services said they routinely share communication needs with other health and care services when patients have given consent. As a result of the inconsistencies, a particular burden is placed onto patients and families to translate, forcing individuals to feel less independent, less in control, and forced to share sensitive health information. People also told Healthwatch that they were uncertain about their rights under the Accessible Information Standard, or where to go for information. The Healthwatch review also found that during the COVID-19 pandemic, many service providers did not meet the requirements of the AIS when making changes to how people accessed care or providing information about the pandemic. This includes information related to COVID-19 which wasn't accessible for all. The Healthwatch review also noted that there are unmet communication needs for people with limited English who are not currently covered by the AIS. Healthwatch. Needs overlooked. Blind people being given forms to order a white cane. Expecting people with hearing loss to book appointments over the phone. Support not in place. Dental practices not getting hearing induction loops installed. GPs refusing people access to a BSL interpreter. Inconsistent service. People not always receiving support, even when services recorded their communications needs. Hashtag Your Care, Your Way. The burden on patients and families. Individuals often rely on family, friends, or carers to translate, making them feel less independent less in control, and forced to share sensitive health information. Emerging AIS Reviews Findings. Emerging AIS Review Findings and Recommendations. The following emerging findings and recommendations are subject to further stakeholder engagement, as outlined in the approach. They have been drafted in conjunction with AIS coalition groups and AIS Programme Board. It should be noted that further work is still ongoing to refine and test out both the findings' recommendations. This includes further workshops and interviews with stakeholders and detailed one-to-one meetings with Healthwatch England, Sign Health, Sense and the Care Quality Commission. There will also be further internal work with the following organisations: DHSC and NHS-E/I policy teams, NHS-E/I Health and Inequalities team, NHS Digital, DHSC and NHS-E/I legal teams, Care Quality Commission. The proposed recommendations will then inform a revised Accessible Information Service Standard, implementation guidance, and best practice guide. It will be available in all formats. Key theme areas identified: the standard, lived experience, impact of COVID-19, capabilities and awareness, culture and provider perceptions, systems and digital, assurance and regulation, quality and best practice. Emerging findings, 1 out of 3. The standard. Number 1. The overall strategic direction of the standard and intention is mostly viewed as positive. However, the scope of the standard needs to be made clearer. In particular, it is regarded as having a primary focus on healthcare services, especially sensory loss. It is viewed as being unclear in how it relates to children and young people. Lived experience. Number 2. Although individuals reported some good examples of AIS implementation, there was inconsistency in its implementation across all need types. All 5 provider steps are inconsistently applied across health and social care providers. Number 3. Many people reported a lack of support in meeting the communication and information needs for people with mental health, autism, learning disability, and other communication needs. Number 4. There are significant implications for people as a result of poor and inconsistent implementation of the AIS, including stress, negative patient experience, and poor health and social care outcomes. People are less likely to engage in health and social care services when their needs aren't met. Number 5. People who should have their communication and information needs met under the AIS are often not aware of their legal entitlement. Emerging findings, 2 out of 3. Impact of COVID-19. Number 6. COVID-19 had a clear negative impact on the implementation of the AIS, where accessible communication and information was not consistently provided at both a national and local level. Capabilities and awareness. Number 7. Providers and staff are frequently unaware of their legal duty to meet the AIS and of how to deliver accessible information and communication for a range of needs. Culture and provider perceptions. Number 8. The overall finding is the standard is not being met across health and social care, with some providers viewing the AIS as advisory, secondary, and optional. Systems and digital. Number 9. NHS and social care information systems are not consistently being used to capture people's communication and information needs, or using them to share information with other organisations. Emerging findings, 3 out of 3. Systems and digital, continued. Number 10. Digital tools and services are not routinely adapted to meet people's specific communication and information needs in advance of the consultation, leading to their needs not being met and increasing their feeling of isolation. Assurance and regulation. Number 11. The AIS needs improved assurance and regulation, with clear consequences for failure to meet the standard. Number 12. People often need to raise a complaint for their needs to be met, which itself exacerbates the inaccessible local complaints procedures. Quality and best practice. Number 13. Best practice elements exist, but they are not shared across providers to improve AIS implementation. Emerging AIS Review Recommendations. Key AIS Recommendation Themes. The Standard. Roles and Responsibilities. Training and Education. Patient Awareness. Digital. Complaints, Regulation, and Assurance. Emerging AIS Recommendations. The Standard. Number 1. Revise the AIS to provide greater clarity on the scope of the standard. Number 2. The current 5-step AIS model introduces a new 6th step to check and/or review. Number 3. That a dedicated NHS E/I team work with DHSC and NHS E/I policy teams. AIS Roles and Responsibilities. Number 4. That a revised AIS clearly sets out roles and responsibilities for commissioners, integrated care boards, providers, Healthwatch, and national organisations. Number 5. The Health and Inequalities Lead within integrated care systems is responsible for AIS planning and implementation. Training and Education. Number 6. AIS training should be mandated nationally for all NHS and social care staff, covering both the AIS and the wide range of communication and information needs. Number 7. An AIS implementation guide incorporating best practice guide is co-produced nationally. Number 8. Increase awareness of the AIS across publicly funded adult social care and social care providers. AIS Patient Awareness. Number 9. A continuous programme of increased national patient awareness of their legal entitlement through locally designed communications campaign. Digital. Number 10. NHS E/I work with NHS Digital to set up an AIS Digital Working Group to oversee the development of an AIS requirement specification. Reflections and questions. John. Training and education. There is a need for training around AIS implementation to be provided to providers and increased awareness of AIS amongst the public. IFA plans to look at accessibility in dentistry in future meetings. John will make suggestions to the Chair of Local Dental Network for West Yorkshire and Postgraduate Dental Dean to provide trainings to dentists. John also suggested including AIS discussion in local care partnership meetings. Tatum. It's important to work on translating the recommendations into practice, as we have known about the issues for a long time. Need more work to be done on enforcement. What can we do differently to improve people's experience this time round? Malcolm. The core thing to make the policy work on the ground is timing. The ICSs have a core role in implementing the recommendation in both BSL and AIS reviews. We have asked one person in each ICS to be the lead to help with designing and monitoring the work and provide support to providers and commissioner. Changes don't happen overnight and have got to be driven locally. For example, BSL Best Practice Guidance is a tool for local services to implement recommendations from the BSL Rapid Review. HWL needs to understand what the levers are, making sure it's a priority. Keep repeating the message. What are the real must-dos? Awareness, quality, and availability. AIS should be in all local policy documents. Syed. Need to look at family structures and involving diverse communities? If so, how? Training and education for staff on their IT systems. The functionality is there, but people don't know how to use them. Carl. We need to move away from thinking that keeping on going out to ask people about their lived experience of failure on AIS is the same as doing something. Everybody knows what the issues are, so the conversation should be about solutions, not just getting input about what the problems are. We need to think about intersectionality. For example, people with a learning disability may also be deaf, and we need to think about how this could affect how they access services. Action 1. John, to find out who the inequality lead is in West Yorkshire ICS, so we can link up with them to move forward the work that we have discussed during the meeting. Actions from last meeting. Majority of last meeting's actions were related to organising this meeting, so those were completed. Helen Butters spoke to a colleague at the CCG and was surprised that the GP practice did not know about Language Empire, BSL in language providers for GP practices. Her colleague says she needs to know which other GP practices are not aware of them, as they need to be made aware. Action 2. Helen will ask CCG Comms colleagues to put information about Language Empire into the CCG's primary care bulletin, so they know about the BSL language interpreting service available to them. Next steps. Plan to organise a joint AIS spotlight session with Forum Central's PSI, Physical Sensory Impairment Network. The session aims to close the loop between what we know and what the providers have done to improve and how this has improved patient experience. Action 3. Tatum will work with Zyra to organise the event. Action 4. Tatum to discuss with Macca about attending other meetings, such as one of the Deaf Forum meetings, so we can share what we know. Next meeting. To be confirmed.